Hello, guys. I'm honored to be hosting this LASID webinar on HAE. It's a recorded video by Professor Andrea Zanichelli, which is well known by the HAE community. Next, please. Hello, Alfonso. And before we begin, I'd like to invite you to attend our biannual meeting, LASID meeting, next month in Buenos Aires from the 15th to 18th of October. Next, please. We are open for calling for new members for LASID committees, so please come with us and help LASID in the community, so you can scan your QR code and you be a candidate for as a member for LASID committees. Next, please. And also, we are calling for a new secretary. The secretary will be in the future LASID president, vice president, and president. So please be candidate for secretary. And we received this invitation to if you want to publish your paper, so you can publish in this collection in clinical immunology in developing countries. So if you want to publish your paper, scan this QR code and you have more information on this. Next, please. And remember that LASID is a partner with the Journal of Human Immunology, and we have the first published volume, so you can go there and check for the published papers. And remember we are always invited to join LASID, to be member of LASID, and to strengthen our community, PID community in Latin America. Next one. And we have the new registry. It's online now, new registry, and so come with us and register your cases on LASID. So now we have the webinar. It's a recorded video, recorded webinar with Professor Andrea Zanichelli, the head of Angioedema Center in the Policlinica San Donato in Italy. He is a graduate in medicine and surgery from the University of Milan and specialized in internal medicine at the same institution, PhD in clinical methodology from the University of Milan. Dr. Zanichelli focus research in internal medicine and angioedema, particularly hereditary angioedema, and has published 115 paper on angioedema in international journals. Next, please. Remember that you can send your question on your QR code on QR session, and we'll try to answer them. And if we and you can send your question to the Dr. Andrea in this email, so will be answered and replied to you by Professor Andrea. Next, please.
Hello, my name is Andrea Zanichelli. I'm a professor in internal medicine, and I'm an expert in hereditary angioedema. So today we will speak about reimagining long-term prophylaxis. So we will speak about the real-world experience with oral long-term prophylaxis. This is my disclosure. So, as we know, hereditary angioedema is a rare genetic disease caused by deficiency of C1 inhibitor that leads to generation of bradykinin, and clinically is characterized by recurrent attacks of cutaneous and mucosal edema. And patients that experience skin edema localized at the face or at hands, feet, at the extremities, cannot do their daily activities, cannot do their work, cannot join social activities. Patients who experience abdominal attack, they might have a pain, colic pain, and with vomiting and diarrhea. And of course, the most severe attack is the life-threatening attack, the edema of the larynx, and patient can die for asphyxia if they're not treated promptly with on-demand drugs. So hereditary angioedema there is a burden of hereditary angioedema related to attacks, but there is also a burden of disease between attacks. So we should speak about total burden of disease. So we know that the burden of attacks, of course, depends on the localization of the attack, on the severity of symptoms, and also on the duration of symptoms, and if patient needs to be hospitalized, to be treated, and impair with life activity of patient. But there is also a burden between attacks. So patient might have a fear of the next attack, might have anxiety or depression related to the disease, and the disease might interfere with educational or career advancement, and also because of the disease, they might change their lifestyle. They might not travel because of the fear of attacks. So we have to speak about the total burden of the disease, and not only the burden related to an attack. And for this reason, the guidelines from the HAE WOW guidelines recommend that the goal of the treatment of this disease is the total control of the disease. So complete control and normalization of patient life. And this can be achieved only with long-term prophylaxis. Actually, there was an evolution in the option of long-term prophylaxis. So we started from the 70s, where only tranexamic acid and danazol were available, and actually we know that the tranexamic acid have a minimal efficacy, and danazol in some patients is effective, but we know that there are several side effects, and I will go in details in next slide about this. And for a long time we didn't have anything else. Then from 2008, plasma-derived C1 inhibitor for intravenous infusion was approved, but is not very convenient prophylaxis, because patient needs to do two infusion of 1,000 unit, infusion of 1,000 unit twice a week. So and we know that to do several infusion, it might be difficult then for patient to organize the infusion. Might be difficult to, there might be some problem with the vein access. So in the last year, there were new modern and targeted therapy that came on the available, and we have now C1 inhibitor subcute that it is similar. It is just C1 inhibitor, but the route of administration is subcutaneous. That is more convenient than intravenous, but still the patient need to inject a large volume of C1 inhibitors. Maybe it's less convenient than other drug as lanadelumab, which is a monoclonal antibody, and we know that patient that start long-term prophylaxis with lanadelumab should inject 300 milligrams of lanadelumab twice every 2 weeks, and then later on, if the disease is controlled, they can inject lanadelumab once every 4 weeks. But then now we are also have available the first oral long-term prophylaxis that can really change the approach to this treatment. So for this reason, the guidelines recommend as a first line all the new modern drugs such as plasma-derived inhibitor, lanadelumab, and berotralstat, and only as a second line, if none of these drugs are available, androgens, because they have side effect, important side effect. So the study with in the 70s with Danatrol was done with 600 milligrams, and only 9 patients were enrolled, and 5 patients were female patients, and they already after the first months already started to report side effect. And in this more recent study, they did a retrospective case series of 74 patients receiving LTP, and they find out that danazol is effective at high doses, 600 milligrams. But when we go down with the dose, when we taper the dose to 400 milligrams and then to 200 milligrams, which is the maximum dose recommended, you can see that only less than 30% of patients can control the disease. We don't know exactly as androgen work. So we know that at a very high dose, they might increase the level of C1 inhibitor because they increase the synthesis of protein from liver. But at the usual dose, so at the dose of 200 milligrams or less, the levels of C1 inhibitor in plasma are far below 50% of normal. So we actually don't really know how it works, but we know very well the adverse effect of these drugs, the drug interaction of androgens and the contraindication. So patients that are on this treatment should be regular and carefully monitored, and they should have a blood test and urine test and a liver ultrasound at least once a year. The most common adverse effects associated with androgens are, of course, mood disturbance, so depression, anxiety, headache, and hypertension, lipid profile changing, and also very important weight gain, and also muscle cramps. And in women, there are several other effects such as amenorrhea, hirsutism, virilization, voice change. So this drug should be avoided when possible. And as you can see in this study from Bork, there almost 80% of patients reported side effect, and 25% of patients discontinued androgens because of side effects. And in this survey, this recent paper that we published, we found an association between comorbidities and androgen use in hereditary angioedema patients. So we compare hereditary angioedema patient that received as LTP, as long-term prophylaxis, androgen, with patients that were never exposed to androgens. And we find out that in patients that were exposed to androgens, there is an increased incidence for hypertension, hypercholesterolemia, diabetes, and liver lesions such as hepatic angioma and focal nodular hyperplasia. So the guidelines also recommend that patients should have an individualized treatment plan, taking into account also prophylaxis. And so when we follow up a patient, we should individualize the treatment following a shared decision-making process. So we should first discover the patient, all the patient medical history, needs, and goal. Then we should discuss with the patient all the option, the treatment option, and then decide together with the patient which is the best option for that patient. So we have to collect data from patient about frequency, severity, localization of attacks. We also have to use some tools such as patient-reported outcomes, such as angioedema quality of life, angioedema control test, and then also ask some questions, some specific question regarding attacks or regarding the access to on-demand treatment. Then we should discuss with the patient all the options available for on-demand and also consider at every visit LTP and also consider patient preferences and also ability to self-administer drug. And then we should decide together with the patient if starting a long-term prophylaxis and the best drug suitable for that patient. And also, this study showed that long-term prophylaxis reduced the burden of hereditary angioedema when we compare it with on-demand treatment strategies. So in dark red, there is the LTP, and in light brown, there is the on-demand. So when we ask a patient on LTP to fill in the angioedema control test, you see that patients on LTP have a very good control of disease, so that reach 14 and the maximum score is 16, while patient on demand, they have an angioedema control test with a score less than 10, which means that the disease is not controlled. And also, when we ask a patient to fill in the angioedema quality of life, you can see that patient on long-term prophylaxis, so dark red, have a lower score compared to patient with on-demand. And a lower score in the AE-QoL means a better quality of life. And also, when we use other questionnaire about generalized anxiety and depression, there is a significant difference between patient on long-term prophylaxis compared to patient on demand only. So as I told you, the new oral therapy for LTP is berotralstat, and berotralstat is a small molecule and is a potent inhibitor of kallikrein. And inhibiting kallikrein then reduce the release of bradykinin, which is the mediator of angioedema. So as you can see, 15 nanomoles of berotralstat reduced the kallikrein activity of 50%, while we need 209 and 210 millimolar nanomolar of C1 inhibitor to have the same reduction of kallikrein. And also in a lab test, about 15 nanomolar of berotralstat reduced almost to zero the release of bradykinin from cell culture. So it's a very potent inhibitor of kallikrein. And if we look at the cascade so if we look at the contact and kallikrein system, we know that when there is activation of factor 12 and factor 12 is not inhibited by a C1 inhibitor, then there is activation of prekallikrein to kallikrein, and also kallikrein is not inhibited by C1 inhibitor, so kallikrein then cleave the high molecular weight kininogen with generation of bradykinin that bind to his receptor on the endothelial cells, and there is the increase in vascular permeability and the edema formation. And berotralstat actually blocked the active kallikrein, so blocked then the generation of bradykinin. Berotralstat has been subject to a robust clinical development program. Of course, went through all the phases of the development program. Phase 1, so on health individuals. Phase 2, so in a small population of hereditary angioedema patient to determine the appropriate dose. And then the phase 3 to provide evidence for efficacy and safety. And regarding the APEX-2, so the phase 3 trials of berotralstat, there were 3 parts of this study. Part 1 that lasts for 24 weeks. Patients were treated with 100 milligrams, 110 milligrams of berotralstat, or with placebo. And there was a significant reduction of patients that were treated in attack rate, in the frequency of attack in patients that were treated with berotralstat compared to placebo. But then the study continued, so went up to 46 weeks and 48 weeks, and all patients were treated with the active drug, either 100 milligram, either 110 of berotralstat. And then the study continued in part 3 in an open label phase, and all patients were treated with 100 milligram of berotralstat up to 96 weeks. And if we look at the efficacy results, we see that patients who completed 96 weeks of 150 milligram of berotralstat treatment experience a reduction of more than 90% from baseline attack rate. So there is already in the first 24 weeks a significant reduction in attack rate compared to baseline. But this reduction is even more after 46 and after 96, 48 and 96 week. So maybe to reach the best results, it takes a bit longer than 24 weeks. And I will comment on this later. And regarding the angioedema quality of life, also there was a decrease in the score of IQOL, which means that there was an improvement in quality of life already in the first 12 weeks, and then this improvement was maintained up to 96 weeks. And when we look at the domain of the angioedema quality of life, we see that compared to baseline, there was an improvement in all the domain: fatigue, mood, fear, shame, functioning, and nutrition. And the best results were in the domain functioning. So about the safety of the drug is safe. There were no safety signal observed with the long-term use of berotralstat, so up to 96 weeks. There are some gastrointestinal adverse events that are reported from 20–30% of patients that usually occur in the first or second months, and then and usually they are mild and transient, so already tend to disappear in the third month. So this is very important to tell to patients that they might experience some abdominal discomfort, meteorism, or maybe diarrhea that is related to the use of berotralstat, but these adverse events are usually transient. So regarding the real-world evidence of the use of berotralstat, we have this data from United Kingdom that show that there was a significant reduction in the number of angioedema attacks compared to baseline, and the reduction increased over time with berotralstat. So this is the attack frequency in the 3 months before treatment with berotralstat. This is the month 1 to 3 of treatment with berotralstat, and you can see that there is a reduction. And then in month 4–6 there was an increase in the reduction. And also when we use the patient-reported outcomes, so if we use the angioedema control test, we see that in the 3 months before use of berotralstat, the disease was not controlled, and there was the angioedema control test was 5, so it means that patients were not controlled. And after 6 months of treatment with berotralstat, you see we reach more than 10, which means well controlled. And in general, also the overall severity score improved. So the severity during treatment with the berotralstat was reduced, the severity of the disease, compared to the 3 months before starting the treatment. And this is a study that we perform in Italy. So these are real-world evidence data from this expanded access program. And so with this program, we could guarantee early access to berotralstat to patients that did not have other available option for long-term prophylaxis, or that did not respond to other prophylaxis, so such as lanadelumab or subcutaneous C1 inhibitor. So before the commercialization of berotralstat, we could start using this oral long-term prophylaxis, and we collect the data on efficacy, on safety, and also on we use the angioedema control test, angioedema quality of life questionnaire. 10 centers in Italy participated in this program, and we enroll about 22 patients, and 15 patients are actually on treatment. And as you can see here, there was a decrease in attack rate from baseline to month 6 of 67% of attack. And when we look at the angioedema control test, we see that there is an increase in over time in the angioedema control test, and we reach 16, which is the maximum score, which means that the disease is well controlled. Few patients discontinued berotralstat because of side effect. A few patients discontinued because of lack of efficacy. One patient discontinued berotralstat because was pregnant, but now she restarted berotralstat, and I will tell you this clinical case. So, in conclusion from this first part of my talk, the clinical trials, in particular the phase 3 trials, provided evidence that berotralstat once daily at the dose of 150 milligrams is an effective and safe prophylactic treatment for patients with hereditary angioedema. And also these real-world studies, so the results of this real-world study confirm the effectiveness and safety of berotralstat. So the results are very similar to those reported in the clinical trials. So I want to share with you some experience with this drug. So a few clinical cases. The first is a woman that was born in 1996 that has a positive family history of hereditary angioedema that was diagnosed very early at the age of three because she started to be symptomatic very early. And at the age of 20, she took part to the phase 2 study with berotralstat, the Apex 1. She was she used the drug, so she was not on placebo arm. She was on the drug arm, and she had 3 attacks per month, and the attack went down to less than 1 per month. She had as adverse event, she reported meteorism and abdominal discomfort, but these mild adverse events were resolved after 2 months. Then she has to discontinue. When she finished the phase 2 study, she could not enter the phase 3 study, so she could not use berotralstat. But then we could ask berotralstat for this patient with a named patient program. So in 2021, she could start again using berotralstat, and as I told you last year, on March last year, berotralstat was commercialized in Italy. So the patient then started commercial berotralstat, and she's still on berotralstat. So she was exposed to more than 70 months to berotralstat. She did not report any adverse effect, and she had a sustained reduction of attack rates. So she passed from 4 attacks per month to 0.75 attack per month, so less than 1 attack per month. This is the clinical case that I was telling you before. So about this lady, 36-year-old, that had a positive family history of hereditary angioedema and has also experienced recurrent episode of abdominal and cutaneous angioedema since childhood. And this patient was started LTP with androgens at the dose of 200 milligrams because at that time there were no other LTP available. But this patient reported several adverse effects related to androgens, such as weight gain, amenorrhea, virilization, moodiness, changes in mood changes, hypercholesterolemia, and hepatic steatosis. So I proposed to this patient to switch to a new modern therapy, because in the meantime, C1 inhibitor subcut was available and lanadelumab was available, but the patient didn't want to start another LTP because of needle phobia. She didn't want a parental drug. So finally, in August 2023, she could take part to this expanded access program that I show you. So she switched from Danatrol to Orladeyo. And Danatrol was tapered after initiation of Orladeyo. And then when she discontinued Danatrol, she continued only with Orladeyo, and she had a complete disease control with Orladeyo and no adverse effect. But then a few months later, so 4 months later, she had a positive pregnant test because she discontinued androgens. She had again menstruation, and she was pregnant. And actually, this was also one of the reasons why she wanted to stop androgens, because she wanted to get pregnant. And estimated conception date was 1 month before. So when the patient told me that the pregnant test was positive, I told the patient to discontinue Orladeyo, because this new treatment are not tested, were not tested, of course, on pregnant women. So she had to stop Orladeyo, and after a while, she started to manifest again angioedema attacks, angioedema symptoms. So it means that Orladeyo was controlling the attacks. And then a few months later, she had to start a long-term prophylaxis with Berinert subcut, which is the only drug that is that can be prescribed to pregnant women. And during her pregnancy, she used always Berinert subcut at a dose of 60 units per kilo. We follow up this pregnancy closely, because the patient was exposed to Orladeyo during the first month of pregnancy. So we follow up carefully this pregnancy, but the pregnancy went well, full term, and the patient delivered an healthy child. Because she didn't breastfeed the child after delivery, she wanted to stop Berinert subcut, because was not convenient to do 2 injection, subcutaneous injection of large volume of Berinert, and she wanted to switch back to Orladeyo. So she, in September, at the end of September, she switched again to Orladeyo with complete disease control. And then I want to share you another case of a female patient, 66-year-old. She had a negative family history, so she's one of these de novo mutation, but her symptoms starting during childhood, and she suffered of recurrent skin angioedema of the extremity and of the face, and also she experienced severe abdominal attacks with vomiting and diarrhea. And she was not diagnosed as hereditary angioedema. Maybe they thought she had some psychological, psychiatric disease, because she was complaining of this pain in the abdominal pain. But then at the age of 22, she had the first episode of laryngeal edema. So she was then diagnosed in 1981 with hereditary angioedema in the center of Milano by Professor Agostoni and Professor Ciccardi. And when they test C1 inhibitor, they find out that both antigen C1 inhibitor and functional C1 inhibitor the levels were very low. So they did a diagnosis of hereditary angioedema type 1. And later on, more in 2015, she was tested again, and as you can see, the level of C1 inhibitor are 110 milligrams per liter, and the normal value is 210 and 390. So these are below 50% of normal value. And we know that the levels of C1 inhibitor are always low in this patient, and they do not change during time. Actually, in the old days, so in 1981, there was only C1 inhibitor available for on-demand. That was the only drug that was available. And it was available only in a center that were treating angioedema. So this patient had to travel to the center for 1 hour and a half by car when she had an attack, an abdominal laryngeal attack, to be treated. So later on, fortunately, she could be treated per month and also reported few laryngeal edema. So in 1989, she started long-term prophylaxis with androgens. And then, because of side effect, the patient tried to discontinue androgens, but when she did so, she manifested again angioedema attacks. But then she had amenorrhea, and she wanted a pregnancy, so she decided to discontinue androgens in 1994. And she was pregnant and gave birth to a daughter in 1996. And later on, she started again with the LTP, with the danazol, with a minimal dose of 50 milligrams per day. And with this dose, she still had some attacks, and she was treating the attacks with icatibant on demand. Then a diagnosis of chronic hepatitis C was done, and she had an increase in transaminase, and also she has hepatic steatosis, and increase in the liver dimension at the abdominal ultrasound. So she has to discontinue androgens. She has to be treated with antiviral treatment for chronic hepatitis. And when the virus, the hepatitis C was negative, the virus was negative, she could start again the treatment with androgens. So the patient, as I told you, so these are the attacks in 2020, from April 2023 up to May 2024, and she was experiencing a little bit less than 1 attack per month. Then in April, she experienced 4 attacks, and beginning of May, other 2 attacks. So she decided to switch to berotralstat on the 14th of May. Actually, the patient was on long-term prophylaxis with androgens. We initiate treatment with berotralstat. So how do we manage the switch from androgens to berotralstat? So there are no consensus strategies at the moment how to switch from androgens to modern LTP, for example, to berotralstat. And we know that there are some also adverse events related to discontinuation of androgens that might be increasing transaminase, and also there is the risk of increase in frequency and severity of attack after discontinuation of androgens. So how should we manage the switch? So should we stop androgens and start the new, before starting a new LTP? Should we tapering androgen and then stop androgen and start a new LTP? Or we should overlapping both LTP treatment. So continue androgen, starting a new treatment, starting berotralstat, and then tapering down androgens after initiation of berotralstat. And this, you can see the free approach. So we draw abrupt discontinuation of androgens, washout period, and then new prophylaxis, tapering androgens, and then discontinuation, and you start another prophylaxis, or tapering androgens after initiation of another prophylaxis, as you can see. So we use the approach, the overlapping approach. So we started berotrastat while the patient was still on 50 milligrams of danazol per day, and we continued this dose for 2 weeks. And then after 2 weeks, we started tapering the androgens. So we gave 50 milligrams every other day for other 2 weeks, and then we discontinued androgens. So let's see how it went. So as I told you, patients started berotrastat at the half of May, and before that she experienced frequent attacks in April and at the beginning of May. After starting berotrastat, she did not experience any attack in May and in June. And then in June, she already discontinued androgens. Then in July, she experienced 4 attacks. And she reported that she had a very stressful period at her work. But actually, we were doubting if berotrastat was working or not. And then we because of what I told you before, so sometimes berotrastat need 3 to 6 months to reach the maximum efficacy. We wait, and actually, as you can see, in August she had only 1 attack. She had 1 attack at the beginning of September, and then, since the beginning of September, she is attack-free. Berotrastat was well tolerated by the patient. She only had mild gastrointestinal symptoms that lasted only for 1 month. And we checked the transaminase during treatment with berotrastat, and they were in normal range, and the patient reached complete disease control. So, in conclusion, switching from regarding the switching from androgens to berotrastat, what we have to know? We have to know that adverse events related to androgens treatment start with the treatment with androgens, and other adverse events are reported in the long term, so such as cardiovascular disease, hypertension, diabetes, or a liver lesion. So we have some adverse events that are reported after the initiation of androgens, and other that adverse effect that will present in the long term. And we also have to know that when we stop androgens, we might have some adverse event related to the discontinuation of androgens, such as increase in transaminase and increase in the frequency of attack. We suggest to overlap the androgens with berotrastat, and after initiation of berotrastat, then start to taper androgens to avoid the increased frequency of attacks related to discontinuation of androgens. And also because berotrastat took some weeks before is at steady state, and so we suggest an overlapping of these two treatment for the first weeks, and then starting tapering down the androgens. There are some patients that are controlled with the androgens, and they might be reluctant to discontinue androgens and to switch to a new LTP, such as berotrastat. Actually, we as a doctor, we should inform a patient on all the adverse effect also in the long term from these treatment. And we patient, once they are informed on this adverse effect also in the long term of the risk of this treatment with androgens, they might be more prone to change, to switch to another LTP. Usually the most accepted treatment is berotralstat, because it's an oral LTP as androgens. So maybe they might not want a parental long-term prophylaxis, such as lanadelumab or a C1 inhibitor, but they accept more berotralstat, the oral LTP. Then how long we have to do the overlapping? So it depends also on the dose of androgen. So the patient that I show you was using a very low dose of danazol, so 50 milligrams. So we starting after 2 weeks to taper the androgens and then to discontinue the androgens. But if patient is on a higher dose, for example 200 milligrams, it might take a couple of months before we discontinue androgens. And what is very important is when we start, when we switch to berotralstat, is the follow-up in the first months. So the first months, second months, the follow-up is very important to for the adverse, to monitor the adverse events. So if patient do report adverse events, so we have to tell them that probably they will be transient and they will disappear after a few months. And also we have to closely follow up a patient for efficacy. So maybe in the first 3 months, patient will not reach the maximum efficacy of berotralstat, but there will be maybe a decrease in attack rate, but still they will experience a few attacks. So we have to explain to patient that if they continue berotralstat, very likely the attack will decrease and they will have a control of the disease. So some practical tips to conclude for the use of Orladeyo. So as I told you, steady state is reached after a few weeks. So if patients switch from another LTP, such androgens, I advise you to do some overlapping period. If patients are naive, so if they are not coming from another long-term prophylaxis, but they come from an on-demand, then we have to tell patients that maybe in the first 2-4 weeks, they will still experience the same rate of attack than before initiating Orladeyo, but they will improve very soon, already from the second or third months, and then it will go better and better, and they will have a maximum reduction in frequency of attacks after 6 months. And berotralstat should be administered with food to minimize gastrointestinal adverse events. And actually, in my experience, there were no problem with the adherence with the berotralstat. So a patient hardly miss any dose of berotralstat. And if patient then miss a dose, they should take the forgotten dose as soon as possible, but they should not exceed 1 dose per day. And also, there is no need for adjustment for the dose of Orladeyo in older patients, and there is no dose adjustment for Orladeyo in patients with mild or moderate renal impairment or hepatic impairment. And then I want to tell you about this study, this APEX study, so open study with berotralstat in pediatric patients. And these results berotrastat for prophylaxis in pediatric patient from 2 years to 12 years were recently reported at the American Academy of Asthma, Allergy and Immunology in San Diego at the end of March. And you can see that this is an interim analysis. There are different cohort of pediatric patient that with different weight and of course with a different age. Berotrastat patients were already exposed for more than 1 year to berotrastat. There were no safety signal, no serious adverse events, and there was and this data already demonstrate the efficacy of berotrastat already since the first weeks in reducing the attack rate in the pediatric population. This is the mean and this is the median attack reduction, and the reduction in attack rate is maintained during time up to 12 months. So this hopefully will be an option or an oral option for prophylaxis also for pediatric patients that of course are more difficult to treat with injection. So with this, I thank you for your attention. This is my university in Milano. This is the hospital where I work, where is my center for hereditary angioedema, and this is my email. So if you have any question, please feel free to reach me and write me an email. Okay, thank you. Ciao.
Hi again. Before my brief comment, I'd like to thank Pint Pharma, the sponsor of this LASID webinar on HAE. Pint Pharma brought to Latin America berotrastat, the first-line treatment for long-term prophylaxis, oral treatment for HAE, and it's an important addition to our LTP arsenal. Now we have IV and subcutaneous twice-a-week plasma-derived C1 inhibitor. We have the every 2 weeks, twice a month subcutaneous lanadelumab and oral berotrastat available. All these first-line treatments are effective and safe, so we can make a shared decision with our patient for LTP, and we can decide with our patients which is the best treatment for that particular patient. We still have a long way to go. Access to LTP in Latin America is not uniform. In Brazil, we have all these drugs approved, but only limited number of patients have access to these drugs, these first-line treatment. Majority of our patients are on second-line treatment like attenuated androgens, like danazol, for example. Once more, I'd like to thank Pint Pharma for bringing Professor Andrea Zanichelli to us. And please, Alfonso, can you share the email? So please send your question directly to Professor Andrea so he can reply to you. By this, we come to an end to our webinar. Remember to join LASID committee. We are calling for new members, and LASID meeting in Buenos Aires for next month. So good night to all, and see you in Buenos Aires.